Hello, everyone. My name is Irene Sonu. I'm a clinical associate professor here in the motility group. It's my distinct pleasure to be moderating our motility session today. So without further ado, I'm going to go ahead and introduce our first speaker. It's my distinct pleasure to introduce Yeoh. He's currently a third-year fellow in our fellowship program, but soon to be, in just a matter of months, a clinical assistant professor here. He's going to be joining our general GI group with a specific clinical focus on obesity medicine. So he's going to be giving a talk titled, "What is the ideal therapy for obesity?"
Awesome. All right. So good morning, everyone. My name is Yeoh. The title of my talk is "What's the Ideal Therapy for Obesity?" This is a very broad topic, so this will be a little bit of a whirlwind tour. I have no disclosures. So obesity has become a global epidemic, as we all know, where obesity, defined by a body mass index greater than 30 kilograms per meter squared, has rapidly increased throughout the world, especially in more developed nations. And here in the United States, we now have a prevalence of obesity of greater than 40% and anticipated to reach about 50% by the end of this decade. So there are a lot of health implications stemming from the obesity epidemic. And within kind of the GI hepatology world, we find that GI comorbidities are actually some of the earliest to manifest in those individuals affected by obesity. So here on the right, we see kind of a diagram with all the different systems that we help to manage, and obesity does not spare any of them. And just to kind of highlight here some of the common benign conditions that we might see, we see that when obesity is a risk factor, the relative risk or odds ratio of these conditions can be increased anywhere between 2- and 4-fold. And oftentimes when we're trying to medically treat a patient with an underlying condition, we may find that they could be refractory to our therapy, largely because we think the underlying obesity continues to drive their condition. There's also a strong impact of obesity on cancer, and this has been known for a long time. Here in this study published about 20 years ago, they actually looked at the risk of death in patients who had class 1 or class 2 obesity, and we actually found that there was the greatest association in those with GI malignancy. So that's the strongest effect. Everywhere: gallbladder, colorectal, esophageal, gastric, pancreatic, and liver. So as a field that really focuses on prevention of GI malignancies, I think this is another important area that we need to be thinking about in terms of mitigating risk for our patients. So the ideal therapy model for the treatment of obesity is a comprehensive treatment team, access to many providers, starting with good primary care, medical bariatricians, endocrinologists, bariatric surgeons, advanced practice providers, registered dietitians, in some cases having psychologists and psychiatrists, physical therapists, and of course gastroenterologists and hepatologists. And kind of the three pillars of therapy are lifestyle modification, obesity medications, and procedures. However, there can be some potential challenges with the delivery of this care model. Typically these exist at large tertiary academic centers or dense urban environments, and many patients don't have access to these types of treatment teams. There can also be long wait times, issues with insurance coverage, or out-of-pocket costs. And so I think there's a huge treatment gap here and an opportunity for physicians who are interested in taking on a greater responsibility in managing this epidemic. And I believe that GI and hepatology is uniquely positioned to actually take on a greater role in managing this disease. So now to kind of narrow the question here, what's the ideal therapy for obesity that can be offered from the GI and hepatology perspective? So first, we have a very strong awareness of the GI manifestations of obesity. We're experts in GI physiology and gut hormones, and I think this gives us a unique perspective on some of the underlying mechanisms that might be driving obesity in the first place, and thinking a little bit more about the heterogeneity of the underlying phenotypes of obesity. We should all have some basic competency in behavioral counseling, dietary modifications, and for those who are more interested, prescribing anti-obesity medications, potentially performing bariatric endoscopy, and managing patients pre- and post-bariatric surgery. So lifestyle modifications, this is really kind of the backbone of the initial approach to obesity medicine. We have physical activity, diet modification, sleep hygiene, mental health. It's kind of the four pillars here. We'll all have some awareness of this, and I'm kind of not going to go into this just due to time constraints. The next thing I'd like to talk about is obesity phenotypes. This is work that was really pioneered by the GI division at Mayo Clinic, Rochester. And here, they looked to see if there was underlying etiologies that they could look at to differentiate the different phenotypes of obesity. And here, so we have a hungry brain, so having kind of abnormal satiation, kind of feedback following meals, a hungry gut, rapid transit, slow burn metabolism, or those who might be exhibiting emotional hunger and kind of binge eating behavior. And what they found is that when they tailored therapy to try and match one of these phenotypes, they actually saw 1.75 greater weight loss compared to standard of care. So I think this is a really interesting area that's still kind of under investigation, and for those who are interested, I'd highly recommend to read a bit more about this. Next, moving on to medications. So the indications to prescribe an anti-obesity medication include a body mass index greater than 30 or a BMI greater than 27 with at least one obesity-related comorbidity. These are the 5 main FDA-approved medications currently in clinical use. We have phentermine, a combination of phentermine topiramate, a combination of naltrexone, bupropion, orlistat, and liraglutide. Now, these medications have been in use for quite some time. They lead anywhere between a modest 5% total body weight loss up to a 10% total body weight loss. But as the field has changed, they're starting to pale in comparison to some of the newer therapies. So I'm sure a lot of you guys have seen a lot of headlines within the last year or so about Ozempic, semaglutide, Wegovy, and this has really kind of emerged within the last year or so. We've heard that celebrities in Hollywood might be using them. Unfortunately, there's now a national shortage of these medications. So what's all the hype behind these new class of medications? So first, to talk about semaglutide, there are 2 formulations of this. The first is Ozempic. This was FDA approved in 2017 for the treatment of type 2 diabetes, and Wegovy, which was FDA approved in 2021 for the treatment of obesity. And that was largely based on this trial that was published in the New England Journal, where patients, about 2,000 patients, were randomized in a 2-to-1 fashion to either receive once weekly injections of semaglutide or placebo. And both groups also received lifestyle therapy. And what we can see is that in the semaglutide group, there was a very impressive about 16% total body weight loss at 68 weeks compared to just 3% with placebo. In terms of using these medications, the GLP-1 receptor agonists, there are contraindications: gastroparesis, history of pancreatitis, multiple endocrine neoplasia type 2, and there are side effects that can limit their use, predominantly nausea, constipation, and diarrhea. Mechanistically, the GLP-1 receptor agonists mimic the GLP-1 hormone that's released in a postprandial way following meals. It has direct effects on the central nervous system, the pancreas, and the stomach, as well as other important indirect effects on the body. Now, a new medication is actually incorporating a different gut hormone called glucose-dependent insulinotropic polypeptide, or GIP. This works synergistically with GLP-1 and has effects on the CNS, the pancreas, as well as adipose tissue. And so this is a very interesting new medication. It's called tirzepatide. It was FDA approved for the treatment of type 2 diabetes last year. And this was a trial published within the last year in the New England Journal, where about 2,500 participants were randomized into 4 groups to either receive placebo or a once-weekly injection of tirzepatide at 5, 10, or 15 milligrams. And what you can see is that at 72 weeks, the high-dose 15 milligram group actually lost a staggering 21% total body weight loss compared to just 3% in placebo. And side effect profile was about the same as the other GLP-1 agonists. So really promising. Moving on to procedures. So first, bariatric surgery. This has long been the gold standard for treatment of class 3 obesity, so a BMI greater than 40, or class 2 obesity with at least one weight-related comorbidity. It leads to the most profound amount of weight loss, but does carry some risks both in the short and long term and requires a hospital admission. And unfortunately, only about 1 to 2% of eligible patients actually undergo surgery for a variety of reasons, and many will just say they don't want an invasive surgery. So within the last decade or so, bariatric endoscopy has emerged as a viable alternative. It's indicated for patients with a BMI of 30 to 50, so we can see there's actually a lower BMI cutoff. It leads to generally less weight loss, but is lower risk and can be done as an outpatient procedure. It can be used as a bridge to bariatric surgery or as a revision following bariatric surgery in those who may have regained weight. And it's excellent for candidates who may be too high risk for traditional bariatric surgery. So these are the FDA-approved bariatric endoscopy procedures currently. There are others that are currently more investigational, targeting the stomach or small bowel, that will be outside the scope of this talk. So we have the intragastric balloon, the aspiration therapy, or the endoscopic sleeve gastroplasty. This aspiration therapy, or Aspire Assist device, was voluntarily withdrawn from the market last year due to financial issues following the COVID pandemic, so that one's out of play. So we're really left right now with the balloons and endoscopic sleeve gastroplasty. So first, to talk about the intragastric balloons, there's 3 FDA-approved versions. The first is Orbera, which is by far the most commonly used device. It's deployed endoscopically, filled with saline, and then removed at 6 months' time. It leads to about a 10% total body weight loss. The next is the Obalon balloon. This is actually swallowed, inflated with a catheter, and then confirmed radiographically. And it's also removed at 6 months' time and leads to about a 7% total body weight loss. Lastly, the newest balloon is called the Spatz adjustable balloon. This is also inserted endoscopically and then removed at 6 months. And what's unique about it is that it can actually be adjusted in volume on subsequent EGD, either to make it larger or smaller based on patient response. So too many side effects, reduce the volume, or not enough weight loss, increase the volume. And that's been shown to have as much as a 15% total body weight loss. There are issues with the balloons, though. There can be some side effects that need to lead to early removal, and it's unclear their long-term benefit as the treatment basically ends at the 6-month time. So another really compelling procedure is the endoscopic sleeve gastroplasty, or ESG. This is an endoscopic suturing device that's used to plicate the greater curvature of the stomach together, kind of simulating a surgical sleeve, leading to a 70% reduction in gastric volume and thought to also delay gastric emptying. Now, this was a much-awaited trial published last year in The Lancet called the Merit trial. It was a prospective multi-center RCT looking at the use of ESG for class 1 and class 2 obesity. And in this trial, about 200 participants were randomized in a 1.5-to-1 ratio to either undergo lifestyle therapy alone or a primary ESG procedure. And in those who were in the lifestyle group, at the 1-year point, we saw about a 2% weight loss, and they could then cross over into the ESG group and undergo that procedure. And in the primary ESG group, we can see that at the 1-year point, there was about a 14% total body weight loss, which was largely maintained at 2 years. And of course, we can see that the control group, when they crossed over, also matched the primary ESG group. So really interesting, compelling results. And kind of because of this study, the FDA approved this procedure for clinical use last year. So to kind of circle back, what's the ideal therapy for obesity that can be offered from the GI and hepatology perspective? So among people who focus in this area, there's an ongoing debate about the single best therapy, whether that's going to be a GLP-1 or GIP receptor agonist or the ESG procedure for kind of durable results. Combination therapy is probably the best when combining a bariatric endoscopic procedure plus a medication will probably lead to the most amount of weight loss, at least from this modality. It's important to know that not every patient is going to benefit from this approach. Some may have really severe class 3 obesity with complications, and you really should go straight to bariatric surgery and be counseled to go down that road. Or others may really benefit more from a lifestyle-oriented approach and may have good success that way. Our goal should still be to build a multidisciplinary team for comprehensive obesity care, as that really still is the ideal care model. And so I think all kind of systems should be moving in that direction. So how can you learn to better manage patients affected by obesity in your clinical practice? There are many obesity medicine guidelines available online. There is an excellent obesity medicine algorithm that's published every other year that has really a comprehensive overview on the clinical management of obesity. There are many obesity CME courses that are both remote and in person. And if you are further interested, you can sit for the American Board of Obesity Medicine certification. Currently, there's a little over 200 GIs in the United States who are boarded in this specialty as well. Thank you.
Our next speaker is a close colleague of mine, Dr. Linda Nguyen. She is our clinical chief and was recently designated master clinician within the School of Medicine. She has a particular research and clinical interest in gastroparesis, and today she's going to be talking about updates on the new societal gastroparesis guidelines.
Thank you, Irene. And so I'm going to apologize ahead of time. One, I will not be here for the Q&A Paris calls, and I will not be missing Paris. So, but if you put your questions in there for me, I will promise that after I'm done sipping my latte and eating my croissants, I will respond. So, what I'm going to do here is really talk about some of the highlights of the recent ACG clinical guidelines, and then provide a framework for how I think about adapting these guidelines. And this more kind of caveats or disclosures is that in terms of updates, it's hard to really update when there are no FDA-approved therapies for gastroparesis except for metoclopramide in 1979. I am still older than metoclopramide, but not that much older than metoclopramide. And you have to remember that evidence-based guidelines are challenging to develop when negative studies outnumber the positive studies. So just kind of keep that in mind as we go through the guidelines. So here in 2022, you'll see the ACG guidelines on my right, and on the left are the best practices. And there are caveats there, and I'm going to go through the guidelines and then touch a little bit on the best practices, which is evidence-based but more expert opinion using the, what's in the literature as well as the experience of the authors. So here are the ACG guidelines, and this was based on using PICO questions. So we have 20 PICO questions, and then you see here the algorithm there. And what I want to point out here, as I mentioned earlier, is if you look at the grade of the evidence, majority are low grade in terms of the evidence. The ones where they are moderate grade, you see here that the red are the ones we tell you what not to do. So there's lots more things that we tell you not to do, and then only one green, which is a moderate grade of what to do. And that one green is the diagnosis of gastroparesis. And I'll go through these and break all these down a little bit. I'm not going to go through all 20, just the highlighted ones. And then I put a little question mark there on pyloric Botox injection, because here you see in number 19 here, based on 2 sham studies, that it's moderate evidence, and we strongly recommend not to do it, but then we put it in the algorithm. So the question mark there is why, and I'll go through that in a little bit. So the green part is the diagnosis of gastroparesis. You have to be really careful about diagnosing gastroparesis. One is, if you're going to order a gastric emptying test, make sure you have a good gastric emptying study, an optimized one. And what does it mean to be optimized? It is to have at least 3 hours, preferably 4 hours of a solid meal. And what you're seeing here is that on the top panel is you take all studies with gastric emptying studies, and you see no correlation between the emptying and improvement in symptoms. But if you only pull out the optimized ones, you do see a correlation. So you want to make sure, if you're going to do it, do an optimized one. But even when you do an optimized gastric emptying study, what you find here, and this is a study from the Gastroparesis Consortium, where they looked at the gastric emptying at entry into the registry and then a year later. And what they found was that, on average, 40% of patients flipped at 1 year. So 40% went from delayed to normal, or normal to delayed. But there was no differences in their symptoms. So you can change groups or change categories, but still have no impact on symptoms. So what does this mean? And this is kind of how I think about gastric emptying, is there's a lot of overlap between functional dyspepsia and gastroparesis. There's clearly a subtype of functional dyspepsia with the epigastric pain syndrome, so not meal-related, with normal gastric emptying. And then there's the, idiopathic gastroparesis predominantly, where it's postprandial nausea and vomiting, a little bit of pain, but really severely delayed gastric emptying. And then there's all that overlap in the middle. So I kind of think of it like IBS, but IBS mixed, where people can have constipation and diarrhea and go back and forth. And patients do fluctuate back and forth. And so I think that's a challenge of, if you repeat a gastric emptying and it's normal, did their gastroparesis get cured? Did it go away? Or is this part of that fluctuation there? And so then moving down the guidelines, they talk about dietary modifications, which I'm not going to go into. There's the prokinetics and antiemetics. And the way I think about the prokinetics and prokinetics is that you have the prokinetic with an antiemetic effect, which is like metoclopramide, domperidone, the 5-HT4 receptor agonists like prucalopride and tegasteride, and then the purely prokinetics, which are the modulin agonists and the acetylcholine receptor agonists. And just a note, and actually I'm going to go back, and you see here that none of these therapies are FDA approved for gastroparesis except for metoclopramide. Prucalopride is approved for chronic constipation. And what you see with constipation is that patients with gastroparesis and constipation tend to have more severe gastroparesis symptoms. And constipation or bowel symptoms are common in patients with gastroparesis. So I screen all of my patients with gastroparesis for constipation because that's something that we have therapies for and we can treat. And you see here the prucalopride, again, which is FDA approved for constipation, does improve gastroparesis symptoms. So if I have a patient with gastroparesis and constipation, then I'll use prucalopride. Prurostigmine, I mentioned earlier, is a purely prokinetic, and compared to bisacodyl, it does improve constipation. So, so once you get beyond the prokinetics, what's the recommendations on antiemetics and neuromodulators here? And you see, again, this is sort of the kind of bipolar nature of the algorithm versus the guidelines, which makes it complicated. Is that first we put central neuromodulators here in the algorithm, but we say don't use it, and this is based on the nortriptyline study, which I'll show. And again, I'm not going to go through all these antiemetics, but this is a list of antiemetic classes and examples of those antiemetics that you can try with your patients, and oftentimes you need to overlap. And this is a list of the neuromodulators and some of the GI effects and potential effects on symptoms and side effect profile. Again, I'm not going to go into all these in details, but this is really there for your reference. And again, this is the nortriptyline study, which used nortriptyline in patients with idiopathic gastroparesis compared to placebo. And essentially what they found was after 15 weeks, there was no difference between the placebo group and the nortriptyline group. There are other centrally acting neuromodulators that we do use in patients with gastroparesis, but you see here the published data is quite weak, so that's why I did not make it into the guidelines. And this was a study that was conducted by Tom Zikos when he was here at Stanford, where he conducted a survey of patients who came into our clinics for nausea and vomiting, and just asked them a list of medications and which ones did they find was most effective. And not too surprisingly, cannabis or marijuana, ondansetron, and promethazine kind of floated to the top, while the others were really not that effective. But overall, given those lists that I showed you, and not surprisingly, because we don't have any FDA-approved therapies, this is a survey of patients and how they feel about their treatment options, and majority of patients are dissatisfied with all the current therapies. So we're really missing the mark for patients in terms of medical therapies for gastroparesis. So if the medicines don't work, what are some of the non-pharmacologic therapies? And I'm going to focus mostly on the gastrocolitic stimulator and the pyloromyotomy or GPOM, and touch a little bit on that asterisk of the Botox injection. So as I mentioned before, there's 2 sham studies that were negative for Botox, but those were all comers with gastroparesis. And in this study, what they did was they looked at the distensibility of the pylorus using the endoflip, which Dr. Kamal talked about earlier, but this is now endoflip of the pylorus. And what they essentially found was that patients with decreased distensibility of the pylorus were more likely to respond to Botox injection. So the asterisk is that Botox there may be a role, but you have to select the patients and not necessarily all comers. And so the G poem, Dr. Clark talked about sort of the E poem. So this is the G poem where you're doing a myotomy of the pylorus. And this is a sham-controlled study where they enrolled patients into G poem versus sham, and they actually had to terminate the study early because there was such a big difference in the G poem group. And you can see here the breakdown in terms of diabetic, post-surgical versus idiopathic gastroparesis, that those were the response rates compared to placebo. And so what would be great is if, can we identify which patients would respond better, to which ones are the most likely ones to respond to GPOM. And this was a study out of France where they followed patients for 3 years using the score. And what they found was that the patients who scored 2 or higher on this scale were more likely to respond to GPOM than those who scored less than 2. And you can see here that the bloating, early satiety were more likely to respond than those with nausea and vomiting. And that's because nausea is a pretty complex symptom. And this is the kind of sensitivity, specificity, and positive predictive value there. What about gastric electrical stimulation? It looks like a little pacemaker. We're not really pacing. Again, this is also a French study. So just to kind of orient you to the vomiting score, higher is better. And so what they found in terms of this crossover is that patients with gastroparesis, their vomiting and nausea scores get better. So how do I apply the guidelines? First, make sure you diagnose gastroparesis and avoid over-diagnosing. I do spend a lot of time kind of undiagnosing gastroparesis, and actually pretty hard to do. And then consider an overlap with functional dyspepsia. And really, this kind of looking at the predominant symptoms. So when patients have kind of pain predominance, I follow more the functional dyspepsia pathway. And if they have nausea and vomiting predominance, they go down more of the gastroparesis pathway. And I always start with dietary modifications. And it doesn't have to be a low-fat, low-fiber diet, because if you think about that, that's a very anti-microbiome diet. So I do more of a small particle diet, so they can eat fiber, but as long as it's blenderized or cooked. And then, especially with the moderate to severe patients, you may have to augment therapy. So not necessarily start one and stop it, but if you start and they have a partial improvement, you may need to layer on. And then address any comorbidities. So patients with gastroparesis often have disordered sleep, migraine, anxiety, and if you can treat those and address those, you may make an impact in their symptoms.
All right, so I'm tasked with spending only 15 minutes to discuss a very gigantic topic, which is bloating. So my talk is titled Gas Bloat, a Modern Epidemic. I'm just going to have you go ahead and review these learning objectives on your own, but the main focus of this talk is just to really emphasize the heterogeneity and also the multifactorial nature when it comes to the symptom of bloating. But I'm going to try to simplify things as much as possible and break it down. And I'm going to finish off the talk really discussing my own personal approach. So let's start off by defining what bloating is. So bloating is subjective, right? It is the sensation of increased abdominal pressure, fullness, and gas. And we juxtapose that to the other symptom or sign of distension, and that's objective, right? We have a visible increase in abdominal girth. These symptoms are oftentimes accompanied by irritation and flatulence as well. So bloating is common. It affects up to a third of the population. It is actually the most common functional GI symptom. It's associated with a decreased quality of life, and bloating and distension oftentimes are distinct entities. Even though a majority of patients do tend to experience both bloating and distension at the same time, there's one study to suggest that only about a quarter of patients will experience bloating without any visible distension. Dr. Che's group looked at the outcomes of the National Gastrointestinal Survey, which involved tens of thousands of patients, and found that about 14% of patients experienced bloating within the past 7 days. So that's about 1 in 7 people that took the survey. And Certain demographics that were associated with experiencing bloating included female gender, being Latino ethnicity, or being under the age of 60. It was associated with many different gastrointestinal comorbidities, including celiac disease, disorders of gut-brain interaction, such as IBS, primarily IBS with constipation, and inflammatory disease as well as Crohn's disease and ulcerative colitis. Bloating is oftentimes accompanied with belly pain, excessive gas, as well as constipation. But what's also really striking about this survey is that majority of people actually never seek any medical care for this symptom. So it goes without saying that the cause of bloating is complex, and the pathophysiological mechanisms are actually poorly understood. But it's thought to be due to a combination of a variety of factors, as you see I've outlined here on this slide. So there may be altered motility of transit. So that comprises of gastroparesis, chronic intestinal pseudoobstruction, or slow colonic transit, otherwise known as colonic inertia. There could be a presence of excess gas. You see it on this schematic here on the right. This actually illustrates how we go about ingesting gas, or what kind of gas is made throughout our GI tract. And you can see here that a majority of the time throughout our entire GI tract, a lot of the gas is actually reabsorbed. But there can be disorders that cause malabsorption or over-fermentation by our gut microbiota, or aerophagia, that can lead to the presence of excess gas. Lastly, which this bullet point here probably is the most important result of, or cause of why people experience bloating, is altered sensation or compensation to gas production in your intestines. And so that's a terminology that we use all the time in the motility world called visceral hypersensitivity. But there's also this concept of abdominal phrenic dyssynergia that may be playing a role as well. So what is abdominal phrenic dyssynergia? So think about it as the pelvic floor dysfunction of your diaphragm, all right? So on the left here, you don't necessarily need to be able to read that small text on the slide, but on the left is what we normally look like when we don't have excessive amount of gas present within our intestines. But let's say we go ahead and eat like a very high fibrous meal, and which does lead to a lot of gas production. So normally what happens is our diaphragm actually compensates. It reflexively will rise or ascend. This is called the normal viscerosomatic reflex. And as a result, that does not lead to any discomfort or any distension that may form. But in people that have abdominal phrenic dyssynergia, the opposite happens. Instead of there being ascension of the diaphragm is actually stiff, and there's paradoxically descension. It contracts, descension of the diaphragm. And because the diaphragm is now descended, there's no real place for all these gas-filled intestines to go except outwards. And so your abdominal wall actually relaxes, and that will lead to not only the visible distension that people experience, but also the sensation of bloating as well. And I'm going to try to cover as many points here. As you can see, there are numerous causes of bloating, but I'm going to try to focus on the most important ones for the remainder of my talk. So, of course, we have to talk about diet when it comes to bloating. Oftentimes, people will experience postprandial bloating as a result of the type, the size of their meal. And so I'm going to talk a little bit about prebiotic intolerance, focus a little bit more about FODMAP, since those are all the rage, and then I'm going to end by talking about carbs. So what are prebiotics? So simply put, prebiotics are nutrients degraded by our gut microbiota. And prebiotics are really, you can think about it as just fiber. Fiber truly is the gold standard prebiotic. But when you break things down, literally, they can be broken down into certain types of disaccharides and carbohydrates. So there's fructans, there's galactose oligosaccharides, resistant starches, and glucose oligosaccharides. And within all the carbohydrates that we ingest on a daily basis, the majority of what we eat is actually comprised of starches. So prebiotics are a very common trigger of bloating, but so are FODMAPs. And I just also want to highlight there's an overlap between what types of foods are prebiotic, what types of foods are high in FODMAPs, and then, of course, what types of foods are carbohydrates. So what are FODMAPs? So FODMAPs, it stands for fermentable oligodimonosaccharides and polyols. It's a mouthful, as you can tell. But the reason why they're so important and focused, there's so much focus on this topic is that they're very highly osmotic carbohydrates, and because of that osmotic effect, that can change your transit time, also lead to distension of your intestinal wall, but also have an effect on your visceral sensation, that visceral hypersensitivity that I touched upon just a second ago. In addition to having a strong osmotic effect, FODMAPs are very highly fermented by your gut microbiota, which leads to a lot of gas production. And it also leads to the production of short-chain fatty acids in your colon. And those SCFAs actually have an added osmotic load, but also can change your luminal pH and lead to all these downstream effects that you can see highlighted on this slide. So the low FODMAP diet is more or less the mainstay of dietary treatment for lots of functional GI disorders, but primarily IBS. And you can see here, I've highlighted on the left here the percentage of patients that experience bloating who have certain disorders of gut-brain interaction, otherwise known as functional GI disorders. So in patients with irritable bowel syndrome, that is constipation predominant, over 90% of people will have bloating. And you can see here on the schematic here on the right, which comes from the Rome 4 criteria that came out now almost over 7 years ago, that there is a spectrum of pain and a spectrum of types of stool, right? Distension, diarrhea and constipation. But it's almost universal that people with IBS are going to experience bloating and distension. People that don't meet that criteria of IBS and they just have constipation, that's called chronic idiopathic constipation. And you can see here again, over 90% of people with CIC are going to experience bloating. Bloating is also exceedingly common in patients with other DGBIs, such as functional dyspepsia, as well as in or disorders of dysmotility like gastroparesis. So constipation, if it was that simple, I probably wouldn't have a job anymore. So the causes of constipation can be quite different from patient to patient. And you can see here I've outlined 4 different types of constipation. There's run-of-the-mill kind of chronic idiopathic constipation. There's constipation as a result of having a slow-moving colon or slow colonic transit. There's medication or induced constipation, and opiates, of course, are a big problem right now, and especially in our country. And then last but not least is pelvic floor dysfunction. And so when you're addressing patients that come to your clinic with constipation, I think it's always a good pragmatic choice to trial some laxatives, but they may warrant some diagnostic testing, and I've outlined here several tests that we could offer. So to measure transit, there's its marker studies and wireless capsule motility study. Unfortunately, SmartPill will no longer be available in the near future, actually. And then to assess for a pelvic floor dysfunction, there's anorectal manometry with balloon expulsion test as well as defecography. I wanted to include this slide here just to highlight that there are numerous prescription strength laxatives that are effective for the treatment of constipation. And I think many clinicians in the room are familiar with linaclotide, otherwise known as Linzess. It's probably my favorite because it comes in 3 different doses, so it's very nicely titratable. There's also lubiprostone, which also comes in 3 different doses, but it's also BID, so twice as many pills as linaclotide. Also has a higher side effect profile in terms of nausea and headaches. But the newer kids on the block are also quite effective, and usually insurance, especially private carriers, will cover them. There's plecanatide, which is a cousin of linaclotide, otherwise known as Trulance. There's prucalopride, which is currently only FDA approved for chronic idiopathic constipation, but I use it all the time in my DGBI patients as well as my patients with gastroparesis and concomitant constipation. There's tenapanor, which is a sodium hydrogen channel blocker. It comes in only 1 dose, 50 milligrams BID. It's quite effective. And then there's an older antiquated drug that I just want to highlight called tegaseride that used to be available with a lot of red tape. It was only available to young women under the age of 65 without any cardiovascular disease because of the risk of ischemic colitis. But somewhat recently, the FDA completely withdrew this drug, so we no longer can offer this to our refractory patients. I also wanted to highlight for opiate-induced constipation, there's 3 other drugs, but also linaclotide and lubiprostone are FDA approved for opiate-induced constipation. But you can see here there's a lot of options. And methyl-naltrexone used to only be available as a subcutaneous injection, but now it's available also oral. And then last but not least is the treatment of pelvic floor dysfunction. Although many patients with pelvic floor dysfunction, otherwise known as pelvic floor dyssynergia, may benefit from laxative therapy, the most effective therapy that will have the best long-lasting results is undergoing a course of pelvic floor physical therapy. And I would be remiss to give a talk on bloating and not discuss SIBO. So what is SIBO? So SIBO stands for small intestinal bacterial overgrowth, and simply put, it's essentially where you have excessive amounts of bacteria or flora in the small intestinal, which is associated with gastrointestinal symptoms, so primarily bloating, gas, distension, diarrhea, constipation, and nausea. So it's normal to have some microbiota within your existing in your small intestine, but we do have a lot of protective mechanisms within our gastrointestinal tract that prevent this overgrowth. So we have acid production, we have bile, proteolytic enzymes, IgA, and then the presence of the ileocecal valve. So any medication, any surgery that's going to perturb these natural protective mechanisms can predispose patients to the development of SIBO. So just want to also say that, we have 20 feet of small intestine. So the amount of bacteria or microbiota really is dependent on which part of the small intestine you're looking at. There are more organisms as you go further down. But there are, our natural microbiome in the small intestine is comprised mostly of lactobacilli, enterococcus, and gram-positive aerobes. Anaerobes primarily are in our colon. So how do we test for small intestinal bacterial overgrowth? Well, the gold standard really is to take jejunal aspirates, which would be done during an endoscopy. It's a very invasive way, and to culture that aspirate, which, of course, Stanford being a tertiary center, we do offer duodenal aspirates here. But really the most non-invasive, simple test is by doing a hydrogen or methane breath test using some kind of sugar substrate. And so one thing the reason why I wanted to include this slide is to really focus on how poor the sensitivity and specificity of breath testing is. And so there's two sugar substrates that we use here primarily to look for SIBO at Stanford. We use glucose and we use lactulose, but I can say with certain confidence that our motility group primarily really only orders glucose breath testing. The reason being is that lactulose has a very high false positive rate and was actually initially created to measure oral cecal transit. And so it wasn't actually created to measure to look for SIBO. But because of that high false positive rate, glucose is used more readily. That being said, glucose does have a high false negative rate. So in the interest of time, I'm not going to talk about how we interpret breath tests, but we just look for abnormal rises in hydrogen and methane levels. And you can get this from the 2020 guidelines that came out through FACG, that there's a lot of antibiotics that are used that can treat SIBO, usually given for at least 7 days. Usually it's, most of us use it for 14 days. But our first line is almost always rifaximin because it's a poorly absorbable antibiotic that has very little side effects because there's very minimal systemic absorption. When you meet when you are diagnosed with SIBO based on methane criteria, it's kind of a misnomer. It's not really representative of SIBO, but it's more of representative of dysbiosis of your whole microbiome as a result of the presence of archaea and producing methane. And so the new terminology is intestinal methanogenic overgrowth. I just wanted to highlight that a lot of practitioners are using double antibiotic therapy based on this study by Pimentel's group, looking at rifaximin and neomycin. It was shown to have more efficacy in alleviating patients' SIBO-associated symptoms. But I also want to highlight that a lot of people did benefit from monotherapy here. So my personal approach is to really see what patients benefit from. In the first line, if I can get away with rifaximin monotherapy, then that's a great strategy to use over and over again. In the interest of time, sorry guys, I'm gonna just kind of blaze over these slides pretty quickly, but I just wanna highlight you can really do breath testing for any disaccharide to look for lactose, fructose, or sucrose intolerance. And one study showed that, especially in an IBS diarrhea subset, that there are some genetic variants that will lead to sucrose isomaltase mutations, and that will lead to decreased sucrose or sucrase isomaltase activity, and that can explain why a lot of people will develop sucrose intolerance. So in conclusion, just to simplify my approach to bloating, I look at food intolerances, look for the presence of DGBI, like irritable bowel syndrome, look for constipation and think about what the causes of the constipation are, dysmotility, and last but not least, SIBO. Thank you. All right, our next speaker is my colleague, also in the motility group. It's Dr. Houssam Halawi. He's a clinical assistant professor in our division, and he's going to be giving a talk called "What Do We Know About Fungus in the GI Tract? Candidiasis, Small Intestinal Fungal Overgrowth, or Normal?"
Thank you, Irene, and thanks everyone for joining us this morning. Thank you. So first, John sent us a very threatening email to keep it short within 15 minutes with his very kind and polite approach. His kindness is the most effective threat, I think. So it's going to be hard to really cover everything that there is on fungus in the gut in 15 minutes. But my goal is really not to do that, but to rather first establish some facts that may beg the question, are fungus in the gut commensal, i.e. Just feeding off of our gut without causing any harm, or are they actual pathogens? I'll describe very briefly esophageal candidiasis, a fairly common clinical scenario in our practice, and then I'll introduce the topic, the highly controversial topic of small intestinal fungal overgrowth, perhaps the most important question in my talk, before I attempt to provide my own verdict on whether these are physiologic or pathologic based on the above information. So what are some of the data that may suggest that fungi in the gut is actually commensal? Yeast was first described in the intestines on autopsies as early as 1839. And it's estimated that about 7% of infants are colonized by yeast on day one of their life, and up to 96% of them are orally colonized by 1 month. Fungi is found in 80% of stool samples from healthy adults. It's detectable in virtually all GI sections in 70% of those healthy adults. But what is the clinical relevance of these findings, if there is one? Most of these organisms are candida. It is thought that if you find aspergillus, mucor, cryptococcus, and others in an asymptomatic individual, these are considered transient passengers. You can find up to 1,000 fungal cells per gram of stool. Compare that to the very high number of bacteria. This is an early study from the New England Journal in the late 60s that basically highlights the fact that you can virtually find them in every segment of the gut. Most of them are Candida albicans, but others are also found as well. So if it's that common to find fungi in the gut, is it just normal to find them? With some suggesting that they've been present with humans for thousands of years, which reminds me really of the H. pylori kind of dilemma, which has been found in mummified human bodies in the Alps that date back to thousands of years. And still, till this day, we always find it incidentally. We always treat it because we know that it can cause problems, but we also know that it might not cause any issue. And there's a controversial topic about, is there any benefit from having H. pylori? So is it the same clinical scenario here? Are we dealing with the same dilemma? Some data that suggest, just a few examples. This is a case series from Wayne State University where they found in critically ill or elderly individuals with multiple comorbidities with unexplained diarrhea, they found fungal organisms in their stool cultures, and they had a dramatic response to antifungal therapy, which highly suggests that perhaps these are causing symptoms and disease. To take it even one step further, in an extreme case, an invasive case of fungal infection can certainly affect the gut. And this is one example of a 47-year-old woman with non-Hodgkin's lymphoma, typically immunocompromised individuals, who presented with hematochezia and diarrhea and was found to have these lesions on a colonoscopy and had a good response to antifungal therapy. I had the chance in my fellowship to take care of this 36-year-old man with ulcerative colitis, also immunocompromised on infliximab, well controlled, who presented with new onset ascites, cough, fever, and non-bloody diarrhea, initially thought to be a flare-up of his ulcerative colitis. But on his colonoscopy, we found basically an ulcerated cecal mass that is seen also on the CT scan, but also these polyp-like, I don't know if it's visible to you guys, but it's polyp-like lesions all throughout the colon, and the biopsy of these gave us the diagnosis with these narrow-based budding yeast, basically histoplasma confirmed on further testing. And all of these normalized after antifungal therapy. This is a more extreme example of a 43-year-old man, again immunocompromised, presenting with an acute abdomen necessitating right colectomy and ileocecectomy, and was found to have necrotic green mucosa with plaque-like adhesions in the terminal ileum, confirmed to be Candida. And this patient passed away from cerebral hemorrhage from disseminated candidiasis. So it is clear that the presence of fungi, typically in immunocompromised, can cause serious disease. So now I'll just briefly touch upon esophageal candidiasis to see if we can give a verdict on this condition. So typically it's caused by Candida albicans, but other Candida species also. It's more common in immunocompromised, but it's not that uncommon in immunocompetent individuals as well. Clinical presentation, fairly specific, odynophagia. Oral thrush could be a clue, but it's not always present. The diagnosis could be made clinically in an immunocompromised patient, but can be confirmed on endoscopic appearance of these white plaques that we see in the esophagus. If we need further confirmation, sampling those either with a biopsy or a brushing in culture can confirm the presence of yeast. The treatment, fluconazole, pretty effective. Recurrence can still be treated with fluconazole because resistance rate is low. This is an extreme case. Obviously, not all of our patients with esophageal candidiasis will have this appearance, but this just to illustrate how extreme it could be. But the question again, if we find this or even a milder version of this, is this responsible for the symptom? We can diagnose this as esophageal candidiasis, but is this what's causing odynophagia? Well, it's hard to argue with this difference with fluconazole. That reported case changed from this appearance to a completely normal esophagus, and the symptoms completely subsided. So let's talk about small intestinal fungal overgrowth. And one of the reasons why it's probably difficult to limit this talk to 15 minutes is because of not how much data we have on this topic, but how much data we still need to learn about this topic in the future. It's described or defined as excess fungi in the small intestine, and I'll come to that definition in a second. It was initially described in immunocompromised patients, HIV cancer patients on steroids, diabetes, elderly, transplant patients. The theory is that abnormal neutrophil chemotaxis and abnormal adhesion and intracellular pathogen killing capacity lead to fungal overgrowth. Clinical presentation, watery diarrhea, mucus in the stool, urgency, bloating, abdominal pain, also chest pain, belching, indigestion, gas, really everything that Dr. Sonu talked about earlier. So very nonspecific symptoms. It's also described in immunocompetent individuals. The mechanism seems to be unclear, but PPI use has been suggested as a risk factor, impaired motility. So let's go back to that definition, excess fungi in the small intestine. There's an inherent problem with this definition, which is the term excess. What is excessive? It was suggested that on an aspirated intestinal juice, the diagnosis can be made if you find Saccharomyces, which Candida belongs to this class, that exceeds 1,000. Partially arbitrary number. Again, the question is not how much fungi do we have in the small intestine, it's rather, is this the cause of the symptom? There are Candida antibody tests, but these lack sensitivity and specificity, but It suggested that they may have a role in assessing efficacy of therapy. In an unpublished abstract in AGA, Satish Rao described that 25% of patients with unexplained chronic GI symptoms have small intestinal fungal overgrowth. Well, that doesn't say, though, that this is what's causing those unexplained gastrointestinal GI symptoms, especially with how nonspecific they are. These are the tools that can be used to sample the fluid, typically from the distal duodenum, preferably from the jejunum. Proposed treatment should be individualized based on authors of these studies, looking at comorbidities, severity of disease, resistance to azoles, intolerance to some of the antifungals, clinical stability, and other clinical aspects. Fluconazole and nystatin are the ones that are typically used, with little information on what is the best dose, what is the duration of therapy that might be needed. So let's see if we can provide a verdict on those two main topics, perhaps to illustrate the contrast between the two. So is the finding of fungus in the gut physiologic or pathologic? First, the question of whether Candida could be a direct cause of adenoaphasia in Candida esophagitis. This is a fairly reproducible, specific clinical presentation. We all see those patients in clinic presenting typically with adenoaphasia, possible dysphagia, predictable risk factors. So I put together these questions to see if I can give that verdict. It's a relatively straightforward diagnosis based on clinical presentation, endoscopic and confirming studies. We have relatively reliable biomarkers, as I illustrated in those images, where finding the white plaques and potentially the biopsies, the samples, can give you a diagnosis, and if needed, it's not always needed, but if needed, can confirm resolution of the condition that should mirror resolution of the symptoms. And we have effective, relatively safe treatments that specifically target Candida, in this case, most commonly used fluconazole, with a satisfactory clinical outcome. So my personal verdict is we have, to borrow some legal terms, sufficient evidence to conclude that Candida is a direct cause of adenoaphasia in Candida esophagitis and should be considered on that differential diagnosis and treated when found. It's hard to argue with these images again. Now, let's see if we can say the same thing about a small intestinal fungal overgrowth. Is it a reproducible, specific clinical scenario? I cannot say that. The symptoms are all very nonspecific, and why not explain them with more common conditions like dyspepsia or bloating or irritable bowel syndrome or pelvic floor dyssynergy, which have the same exact symptoms? And what if the fungal overgrowth is a byproduct of one of these conditions, like constipation, and not necessarily the cause of the symptom? Is it a relatively straightforward diagnosis? I don't think so, because we still need to learn a lot more about the testing, the specificity, sensitivity, and which is the right person to consider those tests in. Do we have biomarkers not yet established? Do we have effective treatments that target fungi? We have antifungals, but the effect of those remains unclear. We still need clinical trials and further studies. So my personal verdict on this question is, again, to borrow legal terms, we have insufficient evidence to conclude without a reasonable doubt that fungi are the cause of GI symptoms in patients with presumed SIFO. So you can prove that there is excessive fungal overgrowth, but that doesn't necessarily mean that this is the cause of their GI symptoms. And my second problem with this question is the treatment is not completely safe. It's antifungal that carries some side effect profile. Until we have, in my opinion, enough data to where we can demonstrate the equivalent of these images in small intestinal fungal overgrowth, I personally will not routinely test for fungal overgrowth and will not empirically prescribe antifungals for chronic nonspecific GI symptoms. I think we should keep our minds open, however, to new data when it comes up. And if there is more evidence in a specific subcategory of patients where the safety and efficacy balance is favorable, then that might change in the future. Thank you.
Our next speaker is Brooke Gurland. She is a clinical professor in the Department of Surgery. She oversees the Pelvic Health Center, which is just across the street, which is a multidisciplinary center comprised of surgeons, gynecologists, physical therapists, and gastroenterologists. She's going to be giving a talk entitled How I Approach Intussusception.
Okay. All right. So full disclosure, I am a surgeon, so I am looking at this from a lens of surgery. I am not going to focus on the medical therapy. I'm not going to focus on the testing. So I'm sort of coming in the middle of a conversation. I'm a very big believer in lifestyle and a very big believer in maximizing all things that you can do before you ever even get to surgery. So maybe like I'm a non-surgeon surgeon. The talk is intussusception. Intussusception can happen anywhere in the GI tract, but we're going to focus on the rectum. And I have very specific objectives today. I'm going to talk to you about grading for rectal intussusception. All right, and because that grading, and so again, I feel like I'm coming in the middle of a conversation. You guys will see something that will be on an imaging test. It will have the word prolapse and anatomy. There'll be specific grades. So today, you're going to walk away with some information about what that grading means, and then what's the clinical significance. All right, and the significance for high grade, right, which is what I'm going to end up focusing on. So I'm giving you the punchline before I've even given you the joke. So like, again, you don't have to listen to everything I say, but there's going to be like that blah, 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 you know that cartoon with the dog and then he just hears his name. So it's going to be about high grade rectal intussusception and why when you have some like internal prolapse, why can that cause anatomic findings? It could cause sphincter damage. You may see some decreasing sphincter resting pressures, inappropriate firing. So these are all things that you know about that you'll see on the testing. And this is why, again, punchline, some high-grade rectal intussusception can cause some anatomic. So I'm going to beat this to death a little bit through the talk. This is an image of what the different grading is, and this was created by the Oxford group. And in the intra, if you kind of group them together, the early stage is in the rectum, the higher stages are in the anal canal, and then lower down right above the sphincter. And once it gets out and it's a number 5, that's external prolapse. And if you've seen it, you can't really miss it. This is, again, looking at with a defecography. Let's see if this plays a little bit. This is a fluoroscopic defecography. And then this is the image. It's not necessarily related to the defecography, but again, the A and B is going to be more of a low grade inside of the rectum, and the C and the D is a high grade. All right, and my next slide, okay, and I'm going fast. Let's see if this plays. Yes. So this is my obsession with animation this year. So I'm going to really bring this home, I hope. Let's see if this works. And I want to fast forward it a little bit because I can't. Let's start here.
Oxford grading score for rectal prolapse categorizes the descent of the rectum through the rectal and anal canal. Grade 1 refers to descent above the rectocele. Grade 2 to the level of the rectocele. Grade 3 refers to descent to the top of the anal canal. Grade 4, descent into the anal canal. Oxford grade 5 refers to full thickness external rectal prolapse.
All right, so what does that mean to all of you? That's a finding on imaging. Leila will talk a little bit more about what testing you get if you have certain symptoms. And so this, which was published in 2012, looked at patients who had internal rectal prolapse. I don't really know if they had dysnergia, they didn't have dysnergia, but this is kind of a report of the percentage of symptoms. A lot of them had obstructed defecation symptoms with repetitive toilet visits, all different ODS symptoms, and then fecal incontinence in 56% of them. And so skipping forward a little bit, or skipping backwards where I talked a little bit about the high grade and what can happen to the sphincter, you can kind of imagine where this anatomy might give you some symptoms like this. This is another animation that I created for patients. All right, let's get rid of this. Let's just...
The uterus sits between the bladder and rectum. The rectum can be thought of as a tube. Chronic straining or poor tissue supports can lead to infolding of the rectal lining. weak tissue supports between the rectum and vagina can lead to bulging of the front wall of the rectum into the back wall of the vagina, known as a rectocele. This infolding is known as intussusception or internal rectal prolapse. Internal rectal prolapse and a rectocele can exist in the same patient. Stool can become trapped in the rectocele, making bowel movements difficult to evacuate, or there can be leakage of stool due to stool retention. Over time, the rectum may descend further through the rectal tube and can narrow the lumen of the rectum, making it difficult to pass stool. When the rectal folds sit above the anus, the rectal tube may stretch the anal muscles. Chronic stretching of the anal muscles can lead to leakage of mucus, gas, or stool. When the rectal folds descend beyond the anal muscles, there is external rectal prolapse.
All right, so you got a little visual. All right, and now let's talk a little bit about the symptom. Right, I beat that one to death. Like you got the scoring. Okay, good. Okay, you're working with me here. All right, so looking at this paper, which talks a little bit about the impact of rising grades of internal intussusception on fecal incontinence and obstructed defecation. So I'm looking more. This is a fecal incontinence scores. This is from a paper that came out several years ago, showing that as you increased the grade of internal rectal prolapse and then went as far as external, the grades of incontinence increased, but not so much when you're looking at obstructed defecation. This is Leila's data. I don't know, I pulled it from her slide deck. She was kind enough to share. And that's when we looked at our patients who have obstructed defecation and fecal incontinence, we found something very similar. As you increase their grade of internal prolapse, all right, not the 0, 1s, and 2s, but when you got to the higher grades, 3, 4, and 5, and we actually found that the 3s are really their own category. They can go in either difference, but as you increase the grade, the fecal incontinence got worse. But you don't have the same findings with the obstructed defecation syndromes. So it's not that as the ODS scores didn't go up with the same relationship. It's sort of all, I don't want to say all over the place, but the ODS scores could be high no matter what their grade was. All right, when we looked at, also Leila's data, when we looked at our patients who had external, or they had some degree of external rectal prolapse or a significant amount of external prolapse that I felt was worthy of operating on, we see that the breakdown is a lot of fecal incontinence, pain or discomfort from the prolapse, but a subset has obstructed defecation. And this ODS group, which Leila will talk about the testing and was mentioned, and Irene mentioned it earlier, that is the most difficult group to treat. I'm not telling you anything you don't know. What about the patient who has this complaint of ODS but doesn't have any significant prolapse? Once they have external prolapse, we kind of know that I don't have a way to treat it without surgery, but it's this ODS group, but no non-significant external prolapse. So their ODS could be from prolapse. It could be an anatomic etiology. I just showed you an animation about why that is. It could be from dysnergic defecation, which you're gonna, all that testing I would have done and looked for in a patient. I would have checked their pelvic floor. Are they a high-tone, non-relaxing pelvic floor? These are all things I would look at. But of course, what happens? People have combined. They have both anatomic and functional components. So you can have underlying defecation disorder. It has led to internal prolapse, and that becomes now more of a progressive disorder. Or you could have an underlying pelvic floor anatomic issue. It starts with internal prolapse, and now they have dysnergia. Like, which came first? We don't always know. So is the intussusception cause of the symptoms, right? Because if I'm going to surgically repair, and I think that we're going to repair this in some way or another, is this really the etiology? So here's the big, what was the non-justifiable evidence that, so like intussusception is identified in 30% of asymptomatic patients. So you can have some degree of internal prolapse in completely asymptomatic people. All right, it's frequently associated with other pelvic floor disorders, and this is a take-home message here. This is like on the quiz. Intrarectal grade 1 and 2 internal prolapse is unlikely to be the etiology of ODS or FI symptoms, and I showed that on the earlier slides. So when you see that on a report, it's not significant. It's not something that you need to necessarily refer. It doesn't mean you don't need to refer for another reason or peace of mind for a patient. But for you, if you see something like an early prolapse, I wouldn't think twice. You counsel pelvic floor PT so that they're maximizing how they defecate. But that is not really that is not something that I would consider clinically significant to operate on. This is an algorithm in the US that sort of talks about what we do with internal prolapse. I would say a mainstay of this is conservative treatment. Everyone gets some sort of conservative treatment, medical management first before ever considering any sort of surgical repair, because the goals of rectal prolapse surgery: restore anatomy, improve function, avoid complications, and avoid new onset constipation. And that is the problem with offering surgery in a group that already has ODS, because there's about a 15% incidence that you could develop new onset constipation from rectal procedures. So there is a changing attitude towards intussusception. In the 90s, publications completely discouraged it. Like surgery was not an option. The posterior rectopexy, which is the traditional prolapse repair where you're suspending the rectum, can result in severe constipation. But the ventral mesh rectopexy seemed to there was all this excitement because it had improved function. The principles of so this is the specific operative repair that I would be offering people. You just work in front of the rectum, mobilize ventrally. I use a piece of mesh, attach it to the sacrum, and I avoid posterior and lateral dissection. And this is from the initial paper, if you can kind of imagine the vagina is in front. I'm not sure that makes any sense to you, but there's a piece of mesh there. And these are kind of the reasons why everybody got super excited that it helped. I'm going to skip this, which is like a little bit of a surgical, what I do in the operation. But the idea behind the ventral rectopexy is that it addressed the anatomic defects, internal prolapse, rectocele, anorectal, descending perineum. When I address surgeon groups, all they want to know is who I'm operating on with ODS and internal rectal prolapse. It is like their favorite question. So here's the data. On internal rectal prolapse and ODS, this is 948 patients, only obstructed defecation, excluded all the external rectal prolapse, goes all the initial papers, mixed everybody together, 11 prospective, 3 retrospective. Everybody failed conservative therapies, including biofeedback, but I have no idea what that meant or yeah, exactly. And these were the imaging that was done on these groups. And what it looked like is in the variety, so they used a variety of ODS scores, but it seemed like at 1 year there was a significant improvement in ODS scores. But when you drill down a little bit further, this is persistent constipation, anywhere ranged from 7 to 35% when they really looked critically at their groups. I'm going to skip this. This is a very nice animation that we created to kind of show patients about relaxing, dysnergic defecation. We actually put them into QR codes, and I've got them in Epic if anybody wants them. I'm going to skip it for the time being, and I'm going to kind of slide. I feel like it's always better to be a little ahead of time than late. And I'm going to talk to you about how I think about the two different groups. So if they have internal prolapse, all right, and the symptom of fecal incontinence, versus obstructed defecation. So if they have fecal incontinence and they're a grade 1 or 2, which you all now know what that means, I'm going to offer them pelvic floor physical therapy and maybe sacral neuromodulation or some of the other therapies like FACG exists. There's other things that you can do for fecal incontinence, but they're essentially treated like a regular fecal incontinence. If they're a grade 3, I'm examining them and I'm deciding, are they a real grade 3? I've become just as good as the radiologist at looking at internal prolapse now, looking on the imaging. Are they like a real grade 3? I can see it on anoscopy. Are they more of a grade 2 that they're kind of overreading? So I make a decision, but everybody gets pelvic floor PT. I want to education and strengthening, and then I'm at my 1 minute. And then I will offer them either a VMR or rectocele, depending on what I think the issue is. A grade 4, I certainly can offer them surgery to suspend the rectum if I believe they're a real grade 4, and a 5 external is usually treated surgically. In the ODS group, all right, grades 1 and 2, pelvic floor physical therapy. If you want to send them, I'm happy to see them, but I'm not going to offer them surgery. The grade 3s, I don't offer a rectopexy for grade 3s. I do not find that those are helpful at all. The grade 4, I have to make a decision, give realistic expectations, and really say, I can fix your anatomy, but I can't promise I can fix your function. And in the grade 5s that have external, again, I can very easily offer them surgery for an anatomy, but realistic expectations about what we can correct. All right, thank you.
All right, next we are literally getting to the bottom of things. So Leila Neshatian, she is the director of our motility group. She's a clinical associate professor here in the motility division. Her talk is titled, How to Best Utilize Diagnostic Testing for Outlet-Related Constipation, Anorectal Manometry, Balloon Expulsion, Defecography, and Dynamic Pelvic MRI.
And sorry for my congested voice and head cold. I will be talking about anorectal manometry, balloon expulsion testing, as well as defecography today. And some of you may ask, why are they important? Because the rectal exam, a good rectal exam, can be really suggestive of the dysenergic defecation. But I have to say that based on the Rome diagnostic criteria for dysenergic defecation, we need to have at least 2 abnormal tests. And the reason to have 2 tests is because these tests are not showing the same results, and they are complementary. They will be not giving us a gold standard test that we can go by, and that's the reason for us to really know about all these tests and be familiar with them. So in terms of the high-resolution anorectal manometry, this is the most widely available and utilized in the clinical practice for the assessment of patients with dysenergic defecation. The test enables us to dynamically observe the intraluminal pressures when the patient is following a series of maneuvers. High-resolution anorectal manometry is the most commonly utilized test currently in U.S. In the paradigm of high-resolution anorectal manometry, we have 2 tests, high-resolution or 2D and 3D or the high-definition anorectal manometry. And there have not been a lot of standardizations for these 2 tests up until recently when the International Anorectal Physiology Working Group came together to provide a framework for indications, interpretation, and techniques to utilize these tests. And in terms of the anorectal manometry, we can assess the anal tone, contractility, coordination between the rectal contractions and relaxation of the anal sphincter muscles, as well as the spinal and supraspinal reflexes. The subtypes of dysenergia are defined by Rao type 1 and 2, where there is evidence of dysenergia based on abnormal contraction of the anal sphincters with or without normal contractions in the rectum. In type 1, with normal contractions, and in type 2, there is lack of propulsive forces. In type 3 and 4, there is lack of proper relaxation of the anal sphincter muscles, again, with or without rectal propulsive forces. But these subtypes are more for research, and they do not provide clinical significance in terms of who will be responding to the treatments with the biofeedback therapy. And the test has been criticized more recently regarding its high false positive rate for the diagnosis of dysenergic defecation, and therefore there have been a number of studies and people who have been trying to improve the utility of the high-resolution anorectal manometry and have suggested that this test should be done in the seated up position as compared to the left lateral position. And indeed, there seems to be some improvement in overall sensitivity and specificity of the test when it's performed in the seated up position as compared to the left lateral position. However, at Stanford and in major other places that we know, the test is still done in the left lateral position according to the current guideline that we have. The other reason for having false positive rate for the diagnosis of the synergic defecation is likely to be related to the normative values. Up until recently, we did not have the normative values for the anorectal manometry. And in the more recent studies, we have been able to identify that there are some differences in men and women, and also according to the age. Specifically, as you can see here, the resting pressure and the rectal-anal gradient, which is the evidence of dyssynergia, seem to be different among men and women and according to age. So when we are interpreting our patients' data, we have to optimize the test results by using the normative values according to their gender and according to their age. The same happens to be apparent for the balloon expulsion test, which is affected by age and the BMI. So balloon expulsion test is usually done in conjunction with anorectal manometry. This is where the 50 ml rectal balloon is filled with water, and the patient will be given privacy in the bathroom, and a 60-second has been set as the cutoff for the normal value. It is an easy test, provides great information about the rectal evacuation dysfunction, however, doesn't give us any etiology in terms of the cause of the dyssynergia or the abnormal evacuation. On the other hand, this is the best test that we have that can predict the response to biofeedback therapy. And this is a very unique aspect of this test because patients who have prolonged balloon expulsion testing are more likely to be responding to pelvic floor physical therapy and biofeedback. Regarding the specificity and sensitivity of this test, there have been some questions about the 60 seconds. And again, they have suggested by decreasing the time to 15 seconds, we may be able to have a higher specificity for the test diagnostic yield. However, this is also, again, affected, as I said before, by age and gender. And these are some areas of research for the future. Squatting stool has been something of interest to many of our patients, and many of the providers have been repeatedly asking the patients to use them. In this clinical trial that was done in Australia, using 3 different balloon expulsion tests without a squatty stool, or with a 7-inch or 9-inch squatting stool, showed that there was no improvement in sense of overall ease of passage of the balloon, in the sensation of urge to evacuate in any of these groups. And overall, the balloon expulsion test did not really, the time didn't really change between the 3 groups, with or without the squatting stool. So according to this test, this is not a recommendation to be made to all comers with constipation. However, when we looked at the effect of the squatty potty or squatting stool, we identified the group of the patients, almost 16% of the patients who had failed the balloon expulsion test. Without the squatting stool, they were able to pass the balloon after we offered them to use the squatting stool. And when we looked at the profile of these patients, we noted that younger patients who had baseline stool with optimum Bristol 3 and 4, and they had a lower resting tone and higher anorectal gradient, were more likely to utilize the squatting stool and have a normal, or rather normal, be able to pass the balloon. So this is an intervention that you may be considering for some of your patients. Let's talk about defecography. Traditionally, barium defecography has been utilized for many years. It is done in the seated position. It has a rather significant amount of radiation, and patients don't like this test. As a result, we have been moving to use the MRI defecography, which has no ionizing radiation and is done in the supine position. The test has become more and more popularized, and therefore we are trying to make it also more standardized. There have been evidence of changes in the anorectal motion and physiology by aging in MRI defecography as well. And overall, the rectal evacuation of the gel seems to be very much in concordance with the balloon emptying test. When compared in head-to-head trials in this meta-analysis, which shows the pooled prevalence of 5 comparative studies, overall barium defecography was very much superior to MRI defecography for the lower grades of the rectal intussusception. Otherwise, it had the same characteristics as compared to MRI defecography for diagnosis of rectocele, rectal prolapse, enterocele, and dyssynergia. And it was much less preferred by patients and well tolerated by patients. I have to remind you that many normal people will have some degree of these anatomical pathologies in the defecographies. And this landmark study that was done many years ago, they showed that up to 50% of men and women had some degree of the rectal intussusception, and the presence of rectocele was reported in more than 80% of patients. In this newer study for more than 600 patients in UK, they noticed that over 60% of patients with constipation who had barium defecography, they had evidence of structural pathologies with rectocele, rectal intussusception, and perineum descent, abnormal perineum descent in more than 40% of these patients. But at the same time, there were more than 10% of these patients who had functional pathologies with dyssynergia. And this is important because in these patients, if there is concurrent functional pathologies, the outcome of the surgery might not be as good as the patients with no functional pathologies, as you heard in the previous talk by Dr. Gurland. So this is, again, you heard it much better than I can describe to you. Just a reminder then is here that the structural pathologies do not explain the symptoms. And you have to really look carefully for the patients, what they are suffering, what they are complaining as compared to the test results. So in terms of the MR defecography, it's a great test for showing the pelvic floor motions, anorectal angle. We have been utilizing the PCL or pivococcygeus line to define the evidence of the muscular pelvic floor descent and also the hiatus diameter. And the abnormal findings here can clue into the pathology for the symptoms of obstructive defecation in these patients. Also, the evacuation of the rectal gel, again, can be determined, which has a good concordance with the balloon expulsion testing. And we can see the abnormal structural pathologies in all 3 compartments in patients, especially women who have concurrent urogenital complaints. And this can clue into the need for surgical or combined surgeries in these women. In this recent study, in a large group of patients and healthy controls where they had undergone anorectal manometry, balloon expulsion testing, and defecography, they noted that there was a good indication to suggest that abnormal balloon expulsion testing, abnormal rectal evacuation, and abnormal rectal anal gradient, which is indicating the dyssynergia, each of them can predict the presence of dyssynergia in patients with constipation as compared to healthy controls. And they all showed that all 3 tests are in concordant when they use the normative values as suggested according to age and gender. Also, they noted that the presence of dyssynergia with an abnormal rectal anal gradient and balloon expulsion test, the combination of the 2 is definitive diagnosis of dyssynergia. So overall, these tests are important for diagnosis of the synergic defecation. They are complementary. They can provide some interesting data into the mechanistic evidence of the underlying pathology. However, we need better understanding of the fact that what's the cause of these pathologies and how to direct the prediction to the biofeedback therapy. Thank you.
Wow, we have lots of questions here, so I'm going to try to get through as many as I can in the next 20 minutes. Question for Dr. Neshatian and Gurland. If almost all patients with suspected anorectal dysfunction get pelvic floor physical therapy, do we really need to get anorectal manometry? Why not just refer directly for PFPT?
I will take over if you don't mind. I was hoping to convince you that these tests, is it on?
Yes.
Oh, okay, good.
Yeah.
These tests are providing information about where should be the focus of the pelvic floor biofeedback therapy. The biofeedback therapy can be tailored towards the abnormal findings in these tests. And not every patient who has constipation will benefit from the biofeedback therapy. This is an important data to remind you that you don't need to send all your patients with constipation without the evidence of or confirm the synergic defecation to the biofeedback therapy, because there are good studies to show that this synergic defecation is the only form of the underlying etiology of constipation that will benefit from the biofeedback therapy, and slow transit constipation will not respond to the biofeedback therapy, if that answers your question.
Is this on? Can you hear?
Yeah.
Okay. So for me, when I look at the testing, if they don't expel the balloon, then I feel like the likelihood of a prolapse being part of their issues is much less. Like, to me, that is a key finding. And then I'm also looking to see, are they a very high tone paradoxical or a high tone non-relaxing? And so pelvic floor PT is going to do different things with them. So I really use that to guide and may say, like, you don't really graduate from pelvic floor PT. Like, you stop for a while, you work on it yourself. They can work on the exercises themselves. But like any type of therapy, they may have flare-ups, they have to go back. So I would say that I really kind of utilize the testing to see how long should they work further. And no, just don't blanketly state to just PT take care of everything.
And if I may add one kind of practical aspect of this, it's nice to confirm the diagnosis of the patients, to be able to tell them we think you're going to benefit. And I've had issues where insurance companies decline to cover physical therapy in patients where we didn't have actual objective data. So while physical therapy is safe, and why not give it to everybody, but at the same time, it is time-consuming, it is expensive, and there are practical issues related to that diagnosis as well.
Great answers. Dr. Halawi, could you comment on leaky gut?
No.
And I figured the answer is going to be easy. And how that may link with bloating and candidemia. Do you ever test for this?
I don't routinely test specifically for candidemia in the setting of functional GI disorders. Leaky gut, I try to kind of explain to patients and go back to the multifactorial nature of those sensory conditions, including the gut permeability, which could be a promising target that we may learn about more in the future. I find it that when my patients focus a lot on one of those aspects that perhaps they heard about or they saw it on the TV, it kind of limits our ability to help them and keeps them focused on exactly that one aspect where we don't really have great ways to diagnose or treat. So I try to help them kind of widen their both of our perspectives towards the management. So I tend to tell my patients it is one of the potential mechanisms perhaps, but we need to learn more about it. And until then, we have these options to try to manage the symptoms. And if we find specific causes like pelvic floor dyssynergy or bile salt, then I tend to focus a little bit more on that aspect.
What do you do when a patient has a positive sucrose breath test for sucrose intolerance, but insurance denies sucrate? Insurance will deny sucrate. It's only FDA approved for CSID, congenital sucrase isomaltase deficiency. It's very hard to get insurance coverage for people that have IBSD secondary to these genetic variants that will lead to sucrase deficiency. So, just as a reminder, these patients that were found to have this genotype or do still make sucrase, right? Just at lower amounts than the general population. So dietary modification will help them. And although socially it may be really hard to completely eliminate sucrose from your diet, you can still try to manage by limiting the amount of sucrose in your diet, and that should be sufficient in providing some clinical relief. What is your approach to patients that bring in results of commercial extensive stool studies? Dr. Halawi?
I was hoping you would take that one. I really, basically, I try to politely not be judgmental towards anybody's approach, but I tell them that our practice doesn't incorporate these not very validated tests. I do acknowledge the limitation in our literature in understanding this. I mean, I think some of those tests are telling us what is in the stool, but whether that's clinically relevant or not is the big question. And recently, I've kind of find it fascinating where patients bring those tests as if to bring you the diagnosis that we could be missing in our clinic, but that someone else has found. And while I keep an open mind towards this limitation that we may learn more about these DNA mapping and hundreds of thousands of bacteria that are listed on those papers, I sometimes genuinely ask them, what did the specialist or the provider that requested the test, what did they suggest? Because I don't know how to interpret those, and we don't use them in our clinical practice, but we might learn more about them. And usually the answer is, well, they don't know what to do with this information. And I think we also don't know what to do with this information. I do believe that we are going to learn a lot more about the microbiome in the future, and hopefully that will help us tailor those therapies a little bit more.
Yeah, I agree with you. I think a lot of the testing that's ordered by naturopaths and are done by companies where the testing is not validated. I tell most of my patients that, I am a true believer that dysbiosis does play a huge role in the pathogenesis of a lot of GI diseases, but we're just not ready for prime time yet to be able to interpret these results. With these new, emerging oral microbiome therapies that are going to be FDA approved for recurrent C. diff, we'll see if down the road we can be using these, therapies down the line to try to reinstate a normal microbiome in these patients with DGBI. So the hope is that eventually we'll be at a place where we can test patients' stool, be able to try to configure it in a better way with these oral therapies, but we're just not there yet. When you suspect recurrence of SIBO, do you retreat empirically with Xifaxan or repeat SIBO test first? So I'm not very pro testing in general. Of course, I do an initial a breath test, but I tend to not repeat the breath test. And just in reality, we also just have such a backlog of tests right now. There's quite a wait time. I tend to go based on symptoms. When you look at the data, on average, patients will get clinical benefit for about 10 weeks after their first course. And data do show that it is safe to repeat a course of Xifaxan therapy. So I do go ahead and just go based on clinical symptoms, and I'll repeat the course for 14 days. If patients have good responses to Xifaxan, do you suggest low erythromycin or azithromycin nightly to prevent recurrence of SIBO? No, I do not use any antibiotic or macrolide prokinetics or antibiotics for SIBO, and I also rarely use them for dysmotility in general, just because of the likely tachyphylaxis, the QTC risks, and also just in this era of antibiotic stewardship, I try to minimize using any systemic antibiotics in my patients, just given they're at higher risk of developing antibiotic resistance, and that can lead to its own set of problems down the road. Rifaximin is often not covered for SIBO and largely not affordable to my patient population. Any pearls to circumnavigate this issue to obtain rifaximin or other preferred treatment alternatives? I tend to utilize metronidazole more often in patients because it is very inexpensive and easy to obtain. But you didn't hear it from me, but I also have patients get a paper script for me and send it to Canada and get rifaximin for about $75 that way. Could SIFO be related to probiotic use, Dr. Halawi?
I don't know if we know the answer to that question. I think just like what I tried to illustrate in my talk, there's a lot more to learn about this topic. In general, my approach to probiotic question that my patients ask me, do I need to take them? Is it good? Is it bad? Is I acknowledge the limited answers we have on this topic, and I say, well, if you tried it and it didn't cause any side effect and it's helping you, then that's fine, but I can't recommend it, routinely for patients. Whether it reduces or increases the risk of SIFO, I don't know. If I'm not aware of specific answers to that question.
Yeah. And I think it seems also counterintuitive to be recommending probiotics in patients that have SIBO or SIFO for that matter, just because, we don't know where the probiotics are going to stick, or, we use this term engraftment all the time. And so if we're going to try to clean out their microbiome with antibiotics, we're probably going to be giving them SIBO again by giving them probiotics afterwards. So
and
yeah.
a lot of times patients are taking all these supplements and probiotics, prebiotics. It's so expensive, yet they come to our clinic. So that's usually how I ask them, well, you're coming to us for a second opinion. Clearly, you're still having the same symptoms or some symptoms. So how about we try to take a step back and stop some of those things and see if we can find a specific cause to target.
Mm-hmm. What do you do regarding incidental yeast on biopsies to screen for EOE for dysphagia without overt fungal plaques and no adenophagia?
That's a difficult question. I tried to look at it. I think maybe John can comment on this. I tend to think that perhaps in some of those cases it's just an incidental finding. Sometimes it's obvious. You see the plaques, they have adenophagia. So what do you think, John?
Yeah, I mean, I go back and forth based on the patient specifically. If it's light and incidental, and I don't see it grossly, and they're on topical steroids, I might just drop the dose down and not treat and see if that gets it better. If I'm not adjusting the dose, then I'll typically treat it just to take it out of the picture. But it's not clear, and I think a lot of times it's a case by case basis in terms of what to do.
Would you use systemic therapy or would you use topical therapy, like nystatin, swish and swallow?
Most times I end up doing fluconazole in that population, but I'll do typically a low dose, short course, and then I'll stop it afterwards. I don't typically look again unless there's something clinically that's changed.
Having a difficult time obtaining neomycin in our region, response to metronidazole has been poor and often poorly tolerated. Any other antibiotics for methanogenic SIBO? So, that slide I showed in my talk did highlight that almost half of people got clinical benefit from rifaximin monotherapy. So you can still get away with rifaximin therapy even in the presence, even if you're treating methane positive SIBO, IMO.
Could you do both? Could you do Xifaxan and metronidazole?
It's a great question. And actually, I was just chatting with a colleague about how we should study this because we're using that a lot more often now. I know a lot of colleagues in our motility group are using double therapy with Flagyl instead of neomycin. I think we just don't know. We need to study this. Yeah.
If I may add one thing about this, I also suggest we always try to treat their constipation when they have methanogenic organisms. And I tell my patients, if we treat your constipation, which often they don't even complain about, but when you ask them, they do have constipation. And if you treat it and the bloating goes down, I personally don't care how much bacteria they have in their gut. And that might save a lot of rifaximin and expense. So I think constipation is
100% agree with you.
is one of the
yeah.
most
And I
common.
used to not. When I saw IMO, I used to not offer rifaximin neomycin first line. I would just treat them with laxatives first line. So yeah, it's kind of this chicken or the egg. Are the methanogens causing slow colonic transit, or the slow colonic transit causing the methanogen buildup? Yeah. All right. Any advice on rifaximin approval for SIBO? That can be a challenge. Stanford, we have a specialty pharmacy that's really great about getting approval. There's also coupons on the website for discounts for patients' first course. Where does workup for celiac and disaccharidase deficiency fall into your algorithm when seeing patients with bloating as the main complaint? I tend to do this mostly if I'm ultimately seeing a patient with symptoms primarily more consistent with IBS-D, but I will do this for IBS-C as well, then I will always look for celiac disease and disaccharidase deficiency. So here at Stanford, we do have a protocol where we will take 3 to 4 pieces of the second or third portion of the duodenum during an upper endoscopy. We send it off for disaccharidase assay testing. It's a send-out test to Mayo Clinic, and the test will essentially let us know the enzyme activity of all your disaccaridases. And so that can help, curate a diet based on those findings. Of course, the most common deficiency we see is lactase deficiency, but you sometimes will be surprised and we'll find other deficiencies with that testing. Is there any concern around medications like Mounjaro and gastroparesis given their mechanism of action?
So I think with the GLP-1 mechanism, one of the key things is actually causing gastric delay. So the GLP-1 agonists, and I believe also tirzepatide, are contraindicated in that population, as it will likely worsen the gastroparesis. The population that actually benefits the most from this class of medication are actually those who may have faster gastric emptying, and so patients who eat and then are hungry again within a few hours. And so by actually kind of utilizing that key side effect from the GLP-1 mechanism, you can reduce gastric emptying and kind of increase satiety.
Another one for you, Dr. Yeoh. Is there a correlation of obesity phenotypes with the type of therapy selection?
So I think, let's see. So yes, I mean, the
you just touched upon
the
that.
goal
Yeah.
is to try and match the phenotype. So again, like let's say someone has what we say is the hungry gut phenotype. That means they're having relatively fast gastric emptying. So in that population, they used liraglutide, which was one of the first GLP-1 agonists. I'd expect that with the newer GLP-1 agonists, we'd see even a better effect. For patients who may have potential other phenotypes that are more behavioral, so hedonic eating or emotional eating, then potentially focusing more on things like bupropion naltrexone is a better candidate. Medication to actually target that is kind of what they had in line with that study. Patients with slow burn metabolism, then the goal is to increase their metabolic rate. So phentermine is used there as kind of a stimulant medication, as well as like strength exercise, trying to increase muscle bulk to increase resting metabolic rate. And the last one, as hungry brain, in that case, I think the medication that was used was phentermine topiramate, which is shown to have an appetite suppressant effect. So those are kind of using, again, different medications to target each one of these phenotypes. It's a little less clear, I think, when there's overlap, but you try and choose the predominant phenotype.
That's great. Last question. I've heard that BMI is not always accurate for obesity. Can you elaborate more on whether this is the case and what other tests have greater accuracy?
Yeah, it's a great question. BMI can be high or low for a lot of reasons. We're thinking about sarcopenia, patients with a lot of muscle, so clearly not the best measurement. I think, what really drives a lot of the pathogenicity from obesity is the visceral adiposity. And so waist circumference is probably the easiest next measurement that can be easily obtained in clinic and correlates better with kind of some of these cardiometabolic outcomes that we see related to obesity. So I would say that is probably the best one. There's other types of assessments of obesity, doing caliper assessments of kind of subcutaneous adipose tissue. There's other studies that have actually looked at cross-sectional imaging. So if patients have a CT scan, there may be a way just to simply look at that and actually understand how much central adiposity might be present. BMI, of course, is readily available, which is why most of the studies use BMI. But yeah, those are different ways of kind of making an assessment.
Great. Thank you, everyone, for answering the questions. So now I invite everybody to join us for Taco Thursday lunch. This is meant to be an informal professor meet and greet session as well, so you're welcome to grab some food and sit anywhere and get to know some of us. We also invite you to go check out the exhibits next door. The lunch is right outside, I believe. It's sponsored by Castle Biosciences. Thank you.